Hi, I welcome you all. Today, I'm going to talk on pediatric deformity or pediatric spinal deformity. Mostly, I'll talk on adolescent idiopathic scoliosis. Recently, I delivered this lecture in a Pediatric Orthopedic Society of Bangladesh meeting. Now, I want to share this lecture with you. This is only on educational purpose, and I don't have any conflict of interest. So let's enjoy the lecture and let's have a discussion on it. So the topic was pediatric scoliosis. This is a systematic approach to classification, decision making, and management protocol. I myself, Dr. ZiaulHasan, I'm an orthopedic spine surgeon from Bangladesh, and I will be talking on this very topic. So when we see this kind of a deformity, like a crooked back, many questions came to our mind whether it is a kyphosis or it is a scoliosis. As she is a very young child, so maybe it is a congenital deformity or something. So it is a bit confusing, and it is very difficult to make a decision how to approach. If we see the symbol of orthopedics, this is a crook tree is trying to make a straight with the help of wires with a straight rods or some trees as well. So ortho plus pedos, that means ortho means straight and pedos means child. So this very symbol of orthopedic also coincides with spinal deformity as well. And if we see the terminology, that means a lateral curvature of the spine more than 10 degrees by Cobb's method on a standing radiograph. So when we put a standing AP view radiograph, we see the lateral curvature. When it is a more than 10 degree, it is called a scoliosis. But to my opinion, this definition does not cover the scoliosis, because for a scoliosis, this is a three-dimensional deformity, and you must have to add a third deformity, that is a rotational deformity with the coronal and sagittal deformity. So this is like a carom coin stroke. When you put a carom coin stroke straight and you include a rotational component with it, it looks like a spinal scoliosis, scoliotic deformity. So there should be rotation as well along with the sagittal and coronal plane deformity. This picture is will help you to understand the rotation. The vertebra rotates into the concave side of the curve. So look, the vertebra rotates into the concave side and body gets pushed on the convex side. So that this two line is very important to understand the rotational deformity, that the vertebra will rotate towards the concavity and the body of the vertebra will be pushed towards the convexity. So towards the convexity, there will be a body push, and also the ribs will be pushed into causing a rib hump. So you will find your rib hump on the convex side of your deformity. So if you see the genesis of the deformity, at first it starts with this small c, then it gradually increase in the dimension, and initially the midline or the line of gravity, it stays in the midline, and when the gravity increase, the midline may be shifted. That red arrow is following the shifting of the midline, and then the proximal and distal, there are two corrective deformity appears, which puts back the midline, the line of gravity into the middle again. So you can see on the third line, the deformity pushing the line of gravity towards the right side of your midline, and then the proximal and distal corrective deformity, or proximal and distal two small curves appears, and it puts back the line of gravity into the middle again. So the pediatric scoliosis is a maybe idiopathic, which is 80% is idiopathic, maybe congenital, maybe neuromuscular, and also maybe syndromic, as there are some other symptoms like Marfan syndrome, Ehlers-Danlos syndrome, neurofibromatosis. These things comes into play. And if we see the idiopathic scoliosis, among the idiopathic scoliosis, we have four types. That means infantile, which is from birth to 3 years of age; the juvenile, which is 4 years to 9 years of age; the adolescent idiopathic scoliosis, which is age is 10 to the maturity, and this is the most common type, AIS. And maybe and fourth type also, the adult idiopathic scoliosis, which is diagnosed after the 18 years. So the first three deformity, like infantile, juvenile, and adolescents, are into the pediatric age group, and the adult idiopathic is obviously the nomenclature is like that. It goes into the adult age group of the idiopathic scoliosis. And for the AIS, or adolescent idiopathic, you will find it in 10 to 18 years. It is the commonest type of the deformity. The cause is unknown, female predominant, and the right-sided curve is more. Usually, this kind of curve don't have pain or neurological deficit, but it is mostly a cosmetic deformity, and also it causes problem in balance of a child when the curve magnitude is very high. So you have to exclude the all other cause of deformity like neurofibromatosis and all other syndromic deformity to diagnose a adolescent idiopathic scoliosis. So it is a diagnosis of exclusion. You need to take the history, clinical examination, imagine. So for the history of the scoliotic child, you need to take history not only from the patients, you have to take history from the parents as well when they observe the deformity. Even the school teacher or the close friends you can include to take the history from, because sometimes the child doesn't even know he or she is having a spinal deformity. So you have to take the history from the society as well. So and then the clinical examination part comes into play, and all obviously the investigation you need to do for planning. So a good clinical evaluation is very important. You have to look at the deformity, whether it is a thoracic or it is a like lumbar or proximal thoracic, whether it is a right-sided or left-sided deformity. How about the rib hump? What about the arm flank distance? What about the neck tilt, pelvic tilt, shoulder height, arm flank distance? So many things comes into your mind, and also you have to check the neurological deficit, obviously, and you have to check for any bowel bladder disturbance as well. And radiograph, you need a radiograph of a whole spine X-ray. Obviously, you need a scoliogram like whole spine with pelvis to check the deformity, and obviously you need a bending field like right-sided bending and left-sided bending field to check the correction of the deformity with the bending. But for doing a bending field, you must have to remind that it must be a supervised bending X-ray. So that means how much patient should bend. Sometimes patient cannot understand, or even the radiographers cannot understand. So you have to send your senior residents or your colleagues or your juniors to with the patient, or even you yourself can go with the patient to the radiology department. And I have seen in good centers they send the doctors with the patient to check whether it is a bending is proper or not. So for a supervised bending, your lower ribs should be touching the iliac crest. That much bend you have to achieve when you do a bending X-ray. So you can use brace, or you can use the surgical intervention as well. When you have a curve angle of 20 to 40 degree, you can use the brace. But more than 40 degree, the brace indication is very limited. You can use the thoracolumbar spinal orthosis, Milwaukee brace. Especially you use the Milwaukee brace when you're you have a high thoracic curve. And you can use the Charleston Knight brace for a single curve of 25 degree, and also you can use the Boston brace as well. So Milwaukee brace, you can keep in your mind that for a high thoracic curve, you use the Milwaukee brace. So for planning, you need to know the curve magnitude, strategic vertebra, and all obviously you need to classify your scoliosis. So for a single thing, if you want to do for a scoliotic curve definition, you check the Cobb's angle. Cobb's angle you measure from the upper end plate of the upper end vertebra and lower end plate of the lower end vertebra, and you put the line together and you get your Cobb's angle, which is very important to define a curve. So for identifying your location of the curve and which one is a major, which one is a minor, which one is structural and non-structural curve, you have to find out your apical vertebra, because in your definition of apical vertebra, you will find the center of your curve and you will find the location of your curve according to the location of your apical vertebra. So if you see the if you find the apical vertebra in T3, T4, or T5, then you can tell this is a proximal thoracic curve. If you find your apex between the T6 and the T11-12 disc in between these two, your curve is a main thoracic curve. When you find the apex from the cephalad border of T12 and chordate border of the lumbar one, then your location is a thoracolumbar. You can tell it is a thoracolumbar curve. And for defining as a lumbar curve, the apex should be between lumbar 1 to disc and the chordate border of the lumbar 4. So by the location of your apical vertebra, you can define the name of your curve and location of your curve. Then the question comes, what is minor curve and what is major curve? So minor curve usually the smaller curves, which have the proximal thoracic curves are always a minor curve. Proximal thoracic curve, this is you can remember like rule of thumb. Proximal thoracic curve is always a minor curve, and minor curve can be a structural but or non-structural. But in case of a major curve is always a structural curve. So major curve is a structural curve and it is the largest curve. So in your three curves, when you find a major curve which is a structural, this is your major curve. So you have to define these curves very well, which one is minor, which one is major. And now come, what is a structural curve and what is non-structural curve? So structural curve is a fixed curve with intrinsic changes like rotation of the vertebra should be there and asymmetric side bending. That means the curve bend 10 degree on the right side, it will not bend 10 degree on the left side. It will bend 15 degree, 20 degree, or 8 degree, 7 degree. So the bending is different on right and left. So for a structural curve, and a structural curve is which Cobb's measurement fails to correct. by your bending field. Although Lenki have a 25-degree cut value that it should become below 25 degree, but the correct definition is a structural curve is a curve whose curve measurement fails to correct past zero on a supine maximum voluntary lateral side bending x. And the non-structural curve is the opposite one, which is completely correct or sometimes even overcorrect on the side bending x-ray, and it has a symmetrical side bending on right and left side. So now, what is compensatory curve? The curve above or below a major curve is a compensatory curve. But you have to keep in mind that a compensatory curve can be structural, because when a compensatory curve stays for a long time, it can be converted from non-structural to structural. So a compensatory curve may be structural or may be non-structural. There are some other things like fractional curves. Fractional curves means when you have a curve proper. I mean, you have a apical vertebra. You know, on the right hand side, you can see the curve starts from the D12 and it ends on the L5. But on the left side, you find a start of a curve, but you cannot find the end of your curve. So this is called fractional curve. And this picture is very important because for planning your scoliosis surgery, you need to know whether it is a compensated or it is a decompensated curve, because these things defines whether the balance is there or not. When you find the deformity on the left side, it is a very big deformity, but still the balance is there. So this is compensated curve. But in the middle picture, you can see the balance is not there, and this is a highly decompensated curves, and it is so much decompensated. This is called a truncal shift. But on the most right-sided picture, you can see a mildly or moderate decompensated curve is there. So you have to know your curve whether there is a balance present or not. Now, the most important part of your scoliosis understanding will be on these few vertebrae, which is called the strategic vertebrae. So strategic vertebrae are like, if you feel like a strategic vertebra, this is if you take a cricket team of 11 players. So for Bangladesh team, if you want to think, you think Mashrafi bin Mortuja, you think Tamim Iqbal, you think ZiaulHasan, you think Mushfiqur Rahman. So they are the strategic players. So if you want to win the game, you have to make them out very early, or you put a big six on those bowlers. So the strategic vertebrae are the most strategic key vertebrae in a team. So on the other hand, you can tell this is a culprit vertebra which cause the deformity. So these are vertebra that makes the deformity. And the vertebra, if you understand well, this vertebra can be best used for a curve correction when you do a scoliosis surgery. And this vertebra that matter to the surgeon is called the strategic vertebra. They are end vertebra, they are apical vertebra, they are stable vertebra, and they are neutral vertebra. So what is apical vertebra? Apical vertebra is a maximally rotated, least tilted, farthest from CSVL line, and the vertebra which is at the center of the curve. So this is more maximally rotation is there, but least tilted. So you need to know your apical vertebra because you have to correct your rotational deformity are all on and around the apical vertebra. So while operating, you need to put screws on both pedicles of your apical vertebra, and you have to put a maximum derotation power in your apical vertebra. So here it is. The end vertebra is a maximally tilted vertebra at both end of your curve, which is closest to the apex. So why you tell the second part closest to the apex? Because if you find maximum tilted two vertebra in your proximal or in your distal deformity, then you take only the closest one, which is closest to the apex. That means for a lower end vertebra, you take the proximal one of the lower two, and for upper end vertebra, you take the distal one of your upper two. So you take the point of that, the closest to the apex. And if you think the neutral vertebra is a neutrally rotated vertebra on either end of your curve, that means the rotation is not there, and the spinous process and is lies in the midline, and the pedicle is equidistant from your spinous process, which is located on either end of your curve, maybe proximal neutral vertebra, maybe distal neutral vertebra. Now, another important vertebra is a stable vertebra. That means if you draw a CSVL line, that line closely bisects your vertebral body and equidistant from the pedicle. So why you need to know this vertebra? Because you need to know your level of instrumentation. That means one is a lower instrumented vertebra you have to know, and in your upper instrumented vertebra you have to know. So for a lower instrumented vertebra, if you know your end vertebra, neutral vertebra, and a stable vertebra, your lower instrumented vertebra should be the vertebra that is the lowest among the neutral, stable, and end vertebra. So you take these three vertebra, and the lowest among these three is your lower instrumented vertebra. Then you have to select your UIV, but that means upper instrumented vertebra. But before that, you need to know your Lenki classification. So I will come back later after your Lenki classification. So initially the classification started, the King classification, and he started with the selective thoracic fusion strategy. But it has some criticism. We know that it has a poor reliability, and King 2 or King 3, that they ignores the sagittal plane, they're non-comprehensive, and so ultimately the Lenki classification comes into the scoliosis surgery. And Lenki, the most important thing is Lenki included the coronal and sagittal deformity into his classification, which was not present in the King classification, comprehensive with a higher reliability rate, and it includes the sagittal and lumbar modifier. So ultimately it has a more acceptability. It has 6 types, type 1 to type 6. It has 3 lumbar modifiers and also 3 sagittal modifiers. So what is Lenki type 1? Lenki type 1 is a Lenki type 1, it is a major thoracic curve. The main thoracic curve is the major, and all of the curves are minor and non-structural. So only one structural curve in the Lenki type 1, which is a major curve. Then you come to the Lenki type 2. Lenki type 2 is a double thoracic curve. The main thoracic curve is the major, and proximal thoracic curve is the minor. So there will be 2 curves, which is double thoracic. Among them, the main thoracic curve is the structural, and the proximal thoracic curve is also the structural. So for Lenki type 2, you get a 2 thoracic curve. For Lenki type 3, you find a 2 major curve. That means a double major curve. The main thoracic curve is the major and structural, and the thoracolumbar or lumbar curve is also structural, but it is a minor. So for Lenki type 3, there will be a double major curve. Among them, the main thoracic curve is a major and structural, and thoracolumbar or lumbar is a minor and structural. For Lenki type 4, you will find a triple major curve. That means the thoracic curve is a major, thoracolumbar or lumbar curve also can be major, and proximal thoracic curve is minor but structural. So either the thoracic or thoracolumbar or lumbar curve may be major, and there will be 3 structural curve. For Lenki type 5, the thoracolumbar or lumbar curve is the major and structural curve. No other curves are structural. For Lenki type 6, this is thoracolumbar or lumbar curve is a major and structural, and main thoracic curve is minor and structural. So this is like if you see the Lenki type 2, the main thoracic curve is major. If you find a Lenki type 3, the main thoracic curve is the major, and thoracolumbar and lumbar is the minor. Here you go for a Lenki type 6, you find the thoracolumbar or lumbar curve is the major, and main thoracic curve is the minor and structural. So there will be 2 structural in Lenki type 6 also. So now you can find your upper instrumented vertebra by this Lenki classification. Now for a Lenki 1, 3, or 6, when you find the right shoulder elevation, you start your upper instrumented vertebra from T2. When you find a level shoulder, you start your upper instrumented vertebra from T3. And when you find the right shoulder elevation, you start from T4. So this is for 1, 3, or 6. When you find a Lenki type 2 or 4, T2 is your upper instrumented vertebra. When you find a Lenki type 5, your upper instrumented vertebra is a upper end vertebra of your curve is your upper instrumented vertebra. So this is how the Lenki classification will help you to find your upper instrumented vertebra. So what is the goal of surgery? The goal of surgery is to optimize the coronal and sagittal balance, produce a level shoulder, and correct the deformity. And you have to think about a fusion to prevent your proximal and distal add-on after the surgery. So surgical correction is indicated for a cosmetic purpose when a progressive deformity, where the curve angle is more than 40 degrees, when there is pain, and when there is neurological deficit. So the rule of thumb is for fusion, the major and structural curves are included in the orthodesis. Non-structural curves are excluded from the orthodesis. So we are at the end. The take-home message is know your curve, classify your curve properly, make the balance right. Don't just correct, you must fuse, and you must have to get a good plan before you operate a deformity surgery. And don't only correct your deformity, you have to do a very good fusion to get a very good result. Thank you all. Thanks for patience hearing.